Bobby, I'd just like to thank you and the Tracks team for working really hard to pull this together. We really appreciate it, and thanks to all our colleagues around the state for allowing us to join you this morning. So my name's Kathy. I head up something called the Neurological Council of WA, and I've got two of my colleagues in the room here with me, and one of them is Kim Hines. She's the nurse consultant here. Next slide, please, Barbie. We're based in the grounds of QE2 campus in a building called The Niche, and in one of the wings in The Niche is a wing called the Centre for Neurological Support. In the Centre for Neurological Support, you can see that we've got all these partner groups that are based here with us, and we just have to like to give a shout out to Janine Collins, who presented earlier, who's a real strong partner and supporter of our service. Thanks, Barbie. I'm whizzing through this really quickly. Sorry, I've got to get my husband who works away to the airport, and I've got to leave at 11:30, so apologies. But you guys don't need me to tell you, but generally in the neurological space, there's over 600 neurological conditions. And if you reflect on the slide I've just shown you previously, in terms of support groups in WA, there's only about 20 structured patient-specific support groups. So straight away you can see that there's about 518 neurological conditions who don't have the luxury of a formal support group in the community. And one of the key things about our service is the way we structure it is we take a whole of neurology perspective, so we can really focus on providing support to the whole of the neurological community. So we know that there's about 1 in 8 people live with a neuro condition, and we know that many neurological conditions lack specialist-specific support. Back in 2001, the health department here introduced a community neurological nurse service, and that service has grown significantly, and it's now in the Metro, in the Southwest, Great Southern, Midwest, and Wheat Belt. We're funded by the state government, and our service is called the NeuroCare Programme. Next slide, please, Barbie. This is a very complex slide, but it's just, if we had more time, we could drill into it a bit more, but this just explains the context behind what we do and the model that we work around. It's called the Neurological Navigation Enablement and Advice Track. So we work with the community around the diagnostic process, being very, very mindful that for many people, the luxury of a diagnosis is not something that they have. And they're living with symptoms that are undiagnosed or very, very rare for a long period of time, which makes it very, very difficult for them to navigate and understand where they can get specific support. So the model that we've developed can work with someone around the diagnostic process, around the management of symptoms if need be, at the point of diagnosis if they're fortunate enough to get a diagnosis, and post-diagnosis, making sure that they're linked into what available services there is, and if there's no available service for them, we fill that gap. And because we are got a wide footprint across the state, we can really develop the concept of a hub and spoke type of model, working out of the Centre for Neurological Support. But one of the key things that we've done over the past 10 years or so is we trialled a project back in 2013 with Bunbury Hospital around a neurological in-reach model as opposed to an outreach model, where our nurses in the community were reaching into the hospital, working with the team there around discharge planning and setting up a patient safely for home, and then working around other support systems that we're in. So RIF as an example, and we heard our colleague presenting on RIF, we've seen our job as adding value post-RIF and filling in gaps around that type of service. So that was really evaluated well in Bunbury Hospital. We then went up into St John of God Midlands when that first opened, and they were unbelievably supportive as a team, from the nursing execs, from all the therapists and the medical team. They were phenomenal in terms of how they accepted our service and worked with us. And we'd just like to give a shout out to the Midland team, who we can see on screen. Simone there. So we did a research project with St John of God Midlands, which we got published a couple of years back, and from that we've been refining the InReach model down in Fiona Stanley Hospital. And we will be looking to do virtual MDT meetings and catch up with the Midland team over the next couple of weeks. Next one, please, Barbie. So people often wonder what it is that we do. I mean, what is a community neurological nurse, and how can we have the skill and competency to potentially support 600 different neurological diagnostic groups? And it's because we've got special skill and competency in the broad area of neurological health management and support. And our therapeutic approach is on the individualised and holistic well-being of the client, regardless of diagnosis or symptom impact. I worked as a nurse practitioner for many years in the UK, albeit 20 years ago now, and we always took a broad neurological perspective on our practice, and we moved away very, very quickly from those very diagnostic specific roles, because we knew that the health service and need couldn't cope with the luxury of having these very defined services. And when I came into this role here, I was very keen to sort of develop the concept of a more generalist neurological nurse role. Next slide, please, Barbie. So we were really, really fortunate back in 2017 when we started developing our service up into the wheat belt to work with some real champions in this area, specifically in the early days, Steph Waters and subsequently Karen Gifford. And we worked with them to identify a service gap in the wheat belt and start looking at how we could maybe fill that. And TeleNeuroCare was the vehicle that we thought that we would jump onto quite quickly and really look to develop. And the team has done the telestroke service has been phenomenal in terms of supporting us, and we've had some grants from the health department, so we've got capacity in all of our small regional offices, as well as here in the Centre for Neurological Support. We've got great resources, and we feel very, very fortunate. And we're now at the stage where a large percentage of our consults occur via the TeleNeuroCare system. Our nurses do tend to do an initial home visit if that's appropriate for the client, if they've got a level of comfort, because our job is very much about working out what that person and that family need, and you can't always get that without some tangible connection in the person's home, because it's often all the things that they're not telling you that as a health professional you feel, you see, you smell, all those non-tangible things that when you're in a person's home, it really gives you an understanding of how they and their family are coping. We very much see our role around filling in gaps around knowledge that may have been provided in the hospital but then has been forgotten or just needs reinforcing. And Janine from Stroke mentioned earlier on about that people, when they come out from the hospital, often feel that they're in a black hole. So our role is very much about picking up that need and looking at what education they need, what support they need, what guidance, and it's very much about the right information at the right time, given in the right context to their family and the broader support network. We're very, very engaged in assessments and using those assessments to set goals and plan care and evaluate. And our role is very much about supporting need now, but preventing accumulation of further need and accumulation of new problems. And we're very engaged in that secondary prevention space. And all of our nurses are accredited, I can never say that word, but accredited smoking cessation practitioners. So we do a lot of work in the risk factor space and really guiding patients to make sure that they've got the knowledge, skill, and resources to make the best decisions for their health. Next slide, please, Barbie. I'm actually going to just flick over this one and the next one quite quickly, but it's just to let you know that what we do is very aligned with the Sustainable Health Review, and the underpinning philosophy of our model is around equity of access and equity of outcome, and making sure that all people with neurological conditions have access to good quality support, because unfortunately what we see in this state and in other places is real proxy values put on people's experiences, and we all see diagnostic groups that are very in favour because there's a lot of promotion or there's a sports star and they get a lot of resources pushed into that area, and that's fantastic. But I think equity of access and equity of outcome, particularly in the current environment, has to be the forefront of all the decisions we make in healthcare, and we're really proud to say that that's been one of the underlying philosophies for our programme for a long time. And the fact that we've got a hub and spoke model and that we can support people out in regional WA really, really helps us feel that we're delivering the best we can with our limited resources. And that's aligning with the Sustainable Health Review. It just allows us to feel comfortable with what we're doing. Next slide, please, Barbie. So this is just a summary of the key partners in our current developments. We've actually been the lead community telehealth community organisation for the past couple of years, and we're really, really proud of that. We're a tiny organisation, but we're really sort of engaged in innovation and thinking about tomorrow and looking at how we can best service the community that we're engaged with. And telehealth has been a phenomenal vehicle to allow us to do that. We're also testing with the health department ABF in a community setting. We're developing GP liaison roles. We're just about to finalise our Fiona Stanley InReach project, and we're writing up that data as we speak. We're very, very engaged in the functional neurology space and aware that that's a growing need that's not supported particularly well, and many of our nurses have been over to Brisbane and overseas to look at skills and ways of developing skills to support the functional neurological area. We provide a lot of support, governance support to the ECU Aboriginal Brain Injury Coordinator role, which is an NHMRC project, and we're really proud of the work that we're doing in that space. We align very heavily with the directions from the Sustainable Health Review. We benchmark significantly what we do with other areas, particularly the UK Walton Centre for Neurosciences, which is leading the way on a lot of community neurological support nursing initiatives. And we do a lot of work with WAFT and things like that. But we just want to say that we are, as an organisation, an early adopter of this technology, and we're totally committed to working with it and working with our community and our hospital partners and colleagues to see how we can develop it further, because all the evidence, all the feedback that we get off our patients is it's really useful for them. And if it's useful for them, it's useful for us, and it's useful to the health service more broadly.
And particularly in our environment at the moment.
Particularly in the environment at the minute, it's perfect. It's a perfect vehicle. So, Barbie, I'm really sorry for that whistle-stop tour.
That's all right. Thank you for staying. Thank you. We've just had one question, Kathy. What's the referral process to NCWA?
Yeah, the referral process to NCWA is people can self-refer. We pull in a lot through GP referrals, MDT meetings. Any of our health professional colleagues can refer directly. You can go onto our website, there's our numbers there, our emails. We try to make it as easy. There's a referral form, but really the easiest way, because we don't want to put a burden on any of our busy colleagues, just phone us and we'll do all the work for you. We just need to know what the need is, that the patient has given permission for us to contact them, and then we can take that on your behalf.